Good evening and welcome everyone for today's session, uh, which is thrombophilia, how to do the workup and whom we should do the workup for thrombophilia and when and what tests we should do it. So first of all, I would like to thank Indian Society of Indian Society of Hematology and Blood Transfusion and Dr. Tufan to give me this opportunity. Today is very interesting day. There is two very important occasion on days. So one is Saraswati Puja, that is Vasant Panchami today, and other is Valentine Day. So people are confused where they should go, but I think who are still with me, they are in love with coagulation. And for next 1 hour, we are going to have a good time on this Valentine Day with thrombophilia. So uh, I will discuss about what is thrombophilia and whom we should test it and what tests we should do and how to interpret these tests. So this is characterized by the increased tendency of venous or arterial thrombosis. So the first time the Virchow, who is the German physician who gave this hypothesis, or we called as Virchow tried, where there is tendency to there is some factor which called hypercoagulability, and there is alteration in the blood flow, that is either slowing or status of the blood, or there is endothelial injury or dysfunction which lead to uh, make this situation for the more of thrombosis. So normally in our body there is two type of proteins, which one is procoagulant and other is natural anticoagulant. So they are in a valence formed. So they keep the things in valence. So the blood, when it is inside the blood vessels, it flows. And whenever there is injury, this proteins goes at that site and form a clot. When there is repair of that particular endothelium, then this clot is lysed by the fibrinolytic pathway. That is what we called as normal hemostasis. Whenever there is any disvalence of these proteins, either procoagulant proteins are increased or natural anticoagulant proteins like protein C, protein S, antithrombin, they decrease. This lead to thrombosis. So before we go into the detail regarding the thrombophilia workup, we should understood how the coagulation pathways works. So I will try to simplify this complicated, which is complicated cartoons, which is looking over your screen. So as we all know, thrombin is the key molecule, and it is generated by the activation of either extrinsic pathway or intrinsic pathway. So the very interesting thing regarding this thrombin, it acts as both procoagulant as well as anticoagulant. So usually this thrombin, I just use the laser point. Okay, so this thrombin convert fibrinogen into fibrin monomer, and it also activate factor 13 in its activated form, which helps in cross-linking of these fibrin monomer and form a stable clot. This is this thrombin is also activate factor 8 and factor 9, which is the part of Tenase complex and which is responsible for the thrombin burst, which is mainly cause the clot formation. This thrombin is also activate the TAFE, that is thrombin activable fibrinolytic inhibitors, which check on plasmin to reduce the fibrinolysis. Along with this is also the thrombin is also acting as um, anticoagulant in the manner when it combined with thrombomodulin, it activates protein C. This endothelial protein C receptors, they potentiate the activity of this activated protein C at least 10 times. Along with protein S, which is cofactor for protein C, they degrade factor 8 and factor 5. So when they degrade that factor 8 and factor 5, there is no prothrombinase complex or kinase complex. That's how they reduce the thrombin generation. Other part, if we see the natural anticoagulant like antithrombin or heparin cofactor 2, they inhibit the factor 11, factor 2, factor 10, and thrombin directly. So that's how these natural anticoagulants is also included. Along with that, the fibrinolytic pathway is also very important. So as we all know, the plasminogen converted into plasmin by either urothelial plasminogen activators or tissue plasminogen activators. And this plasmin degrades this fibrin into fibrin degradation product. So this activation is also checked by the plasminogen activator inhibitor 1. And there is also this plasmin can directly activated by factor 13 or bradykinin also. And the inhibitor of for this is TAFI and alpha-2 antiplasmin or alpha-2 microglobulin. So this knowledge we should have before we go into detail of thrombophilia. So there are many causes for thrombophilia. We divide it broadly into acquired causes and inherited causes. So always remember that acquired causes is always common than the inherited. So inherited causes are very rare. So major acquired causes, if we see that surgeries, prolonged immobilization, pregnancy, oral surgical contraceptive, or the conditions like APLA, PNH, solid malignancy, or HIT, and so on. If we see the inherited part of this thrombophilia, then there is either loss of functional mutation or gain of functional mutation, like protein C, protein S, or antithrombin deficiency, factor 5 mutation, or prothrombin gene mutation, and other related factors, and so on. So we will go in detail with one of one. So if we see the overall prevalence of these different entities, then factor 5 mutation heterozygous is most common one, followed by the other elevated factors. And as we see in this chart, the protein C, protein S, and other rare deficiency is being there. So question comes, whom we should test it? So the recommendation says that inherited thrombophilia cases we have to investigate for these thrombophilia workup. And when we decide that there is no other cause or no acquired risk factor associated, and it is idiopathic type of thrombosis, then we should do this thrombophilia workup. So different guidelines here I have taken from ISTS. This says the recommendation is idiopathic thrombosis that is in young adults less than 50 years, or there is history of recurrent thrombosis, unusual site thrombosis like mesenteric vein, splenic, portal, or hepatic or cerebral vein thrombosis. This next is first degree of related with thrombosis if they are less than 50 years of age, and any event which is occurring during the pregnancy, or the patient who is on oral contraceptive pills and they get the thrombotic events. So here is an example. There is two type of situations. One is 25-year-old male diagnosed with pulmonary embolism after a 6-hour flight. The other situation is there is 75-year-old male patient who has developed pulmonary embolism, and it is discovered that he has extensive clot in his peripheral inserted central line, and post-operatively after 2 days and after a major hip replacement surgery. So in which case we should do a thrombotic workup. So definitely we have to do it here because this is a young patient and the precipitation factor is not a major one, it is stable. So this patient we have to investigate because it's a young patient, there are more chances of inherited thermophilia and this. However, from the history and other things, there is multiple risk factors which can lead for clot formation or increased hypercoagulability. So this is a situation where we should not work for the thrombophilia. So again, the question comes, if anybody has diagnosed with inherited type of thrombophilia, so do we screen all the relatives or not? So as we know, majority of these inherited thrombophilia are transmitted autosomal dominant fashions, and they have the variable expression into the other people. So what recommendation says, there is no testing of healthy or asymptomatic children less than 15 years of age who is the first degree relative of a patient with inherited thrombophilia. Because as I told, the penetration is different, the presentation is different, and risk of this thromboembolism is very low. So that's why they don't recommend in such young children for them. But still, this topic is very controversial, whether the first degree of relative should be screened or not. But finally, what I got from the different articles is they said the testing can be benefited on selected adult patient because they can be decision making for use of prophylaxis of anticoagulant in the time where the risk of thrombosis is increased, like prolonged travel, OCP use, or before surgery. So that these are the selected population of persons asymptomatic relatives where we can do thrombophilia workup before any of this situation. So now you know whom we should test it. So the question comes when we should collect the samples. So the testing should not be performed in acute stage of thromboembolism or any patient who is on anticoagulant therapy. The reason is there is usually conjunction of these different proteins or factors, or there is increase of other factors which can give you false positive or false negative results. And on when the patient is on oral anticoagulant therapies or any type of anticoagulant therapy, they can interfere the test which we are going to detect these deficiencies. We should also have a good medical history of the. We should inquire about the whether the patient is in DIC or having any liver dysfunction or renal dysfunction, because they can give you the false results. As in DIC, majority of the factors they conjunct. In liver disease, there is reduced synthesis of protein C, protein S, other proteins which are produced in the liver, or in renal disorders where it is extremely low. So what tests we can do in these two conditions, either acute phase or the patient is on oral anticoagulant? So these few tests like factor V leading mutation, prothrombin gene mutation, or MTHR, or any PCR-based testing we can do. However, antigenic assays like anticardiolipin antibody, anti-beta 2 antibody, and glycoproteins, we can do it, but not lipocytically. So when we should collect, when we the sample, when we are going to do a functional assay or plot-based assay for like protein C, protein S, or antithrombin. So as I told, they should not be collected during acute phase or anticoagulant or during the pregnancy. They can, if the patient is on oral anticoagulant, that can be sample can be taken if the treating physicians can think that we can stop the drugs for 2 to 3 weeks. Then the patient who are on vitamin K antagonists, they can be. For dogs, usually at least 2 days washout period should be given, but preferably more than 4 days. For unfractionated or low molecular weight, we can stop. We can give the first dose in the morning, and next after 24 hours, giving before the next dose, we can take the samples. However, we have to interpret the result with the guidance. If patient is pregnant and the test is abnormal, then we should again repeat the test after 2 to 3 months after the pregnancy. If a patient is oral coagulant, then other protein, other procoagulant factors like factor 8, factor 7, these can be decreased, increased. So the result should be also intermediate with the questions. So one thing is very commonly asked in the lab that we cannot take the sample during when the patient is on anticoagulant. So never ever ask the patient to stop the anticoagulant, then give the samples. So just talk to their physician and ask them whether he can do it or not. If it is not at all possible that patient is in high risk and they think that we cannot stop the anticoagulant, then it is better going for the molecular testing. So what are the investigation where we can find that this patient having this particular deficiency or this can be suggestive of it? So simple tests like hemogram and typhoid smear. If you find macrocytosis, so are we dealing with the increased homocysteine levels because there is poly or other deficiency can interfere and they can also cause the macrocytosis. Similarly, in sickle cell anemia, the thrombosis is very common. If we find sickle cells on the peripheral blood, that can be suggestive of this the reason for thrombosis. Or PNH, where microcytic hypochromic patient present with hemoglobinuria, we do the PNH testing, so we will find the cause. If the hemoglobin is normal but platelet count is markedly increased and marrow shows the characteristic feature of essential thrombocytopenia, that is the one condition. Or polycythemia, where the hemoglobin is increased below the above cutoff level according to the WHO criteria, then we can think of these simple tests can also suggest what could be the cause for thrombosis. To come to the particular coagulation test, which is of today's topic. So what are the screening coagulation tests which we routinely do in our lab, which can suggest, it is not confirmatory, but it can suggest what we are dealing with. If APTD is short in and you have ruled out that there is no activation or traumatic samples, and you find the increased level of factor 8 fibrinogen or 1 variant, as I told in last slide, we have seen that these are the increased factors also associated with hemophilia. If the APTD is increased and there is no acquired causes for increased APTD, then we can think of whether it is patient of lupus anticoagulant or it factor 12 deficiency, because they are also associated with increased thrombosis. If PT and APTD are both are increased, so is it DIC or it is dysfibrinogenemia, which is has the propensity towards the thrombophilia. If PT and APTD are both normal, so these are the following conditions which can be done, which can be one of the cause for thrombosis. So we have to do a specific assay for them. So first of all, we discuss what is factor V Leiden mutation. So it is one of the most common inherited thrombophilia, and prevalence is around 20% of new cases who are diagnosed with thromboemboli. So it is mainly, these patients mainly present with deep or superficial vein thrombosis and less frequently with pulmonary embolism. There is genetic defect in the point mutation of factor V gene, which leading to the substitution at position 5 gives 6 with arginine to glutamine. So a simple arms tracer which we can do where one mutant allele and one is a wild allele. So if this is the positive control, here one this patient this is control of heterozygous where mutant allele and both wild allele are there. And this is negative control where there is no mutant allele. So this is the patient sample. So after the PCR, we can run the gel and we can find out if there is both are there, then it is a heterozygous for factor V Leiden mutation. If there is no wild, only mutant allele, then it is homozygous. So other test which is important is APCR, which is called as resistant to activated protein C. It considered to be a surrogate marker for factor V Leiden mutation, and approximately 95% they show the correlation with this. So what is happening in this APCR test? So this APCR, activated protein C resistance, is due to this mutation, it abolished uh, the cleavage of APCR acting on factor 5. So that's why the factor 5 is not inhibited, where in the normal sample it should be. Okay, so that's why in normally when we add activated protein C, it prolongs the APTT or whatever PT or DRBT based test, it prolongs. But if this factor 5 related mutation is there, if they are not able to inactivate this factor 5, so that's why the APTT or other plotting time is shortened. So this is the basically principle for this APCR test. So it could be, as I told, APTT waste or PT waste or DRBT of factor 10 waste test. So how we do it? Once we incubate the sample with activated protein C and one without activated protein C. So the ratio of both, if it is more than 2, we consider it is no mutation in there. If it is less than 2, then we consider there is mutation in factor 5 variant. This can also be calculated by the normalization ratio, which the formula is given over here. So if the normalized ratio is less than 0.7, then it is very confirmatory of presence of heterozygous factor 5 variant mutation. If the ratio is more or less, then we can consider it is for homozygous. So there is limitation of this test. This test can be falsely positive when the patient is on anticoagulant in pregnancy where the factor 8 levels are increased, or if protein C deficiency is there, or there is presence of lipase anticoagulant. So these all things we have to keep in mind when we are interpreting the results of APCR. So other thing which we can do is prothrombin gene mutation. So it is a point mutation, and it is the second most inherited cause for thrombophilia. And these patients usually present with DVT and pulmonary embolism. The risk of thromboembolism is 2 to 4 times as compared to the patient who don't acquire these mutations. So there are PCR based method where we can do the testing for these tests. Other thing is methylene methylene tetrahydrofolate reductase polymorphism gene. So as we know, this is an important gene which is necessary for the metabolism of homocysteine. So this particular gene has a variable expression and polymorphism. So this can we also do by the PCR methods of different techniques. And there is also increase the level of plasma homocysteine. So come to the test which we routinely do in our lab. Usually we routinely do protein C, protein S, antithrombin, and APCR. These are the tests which we usually do for in our labs. So as we know, protein C and protein S are the vitamin K dependent glycoprotein, and they are act as a natural anticoagulant. So these disorders usually inherited as a dominant autosomal dominant disorders, and protein C deficiency could be type 1 or type 2. Type 1 usually a quantitative deficiency when both antigen and activity is reduced in a same proportion. However, type 2 is when the antigen is normal but activity is reduced. So these deficiency, protein C deficiency, has high risk of developing thrombosis in the family, and these patients mainly present with DVT and pulmonary embolism at younger age. And we have seen this picture many times, that is called neonatal purpura fulminans, which is due to the deficiency of homozygous or compound homozygous, or child is heterozygous where vitamin K antagonist or some other anticoagulant has been given. So there are two types of assay which is mainly present in the lab. The functional assay and antigenic assay. Antigenic assay is mainly ELISA-based. In functional assay is either plot-based or chromogenic-based. So what is recommended is chromogenic assay because they do not interfere with majority of the other variables. So what is the principle for functional assay? Here we incubate the patient platelet core plasma with phospholipid and contact activator and protein C activators, which can be either snake venom or other things, usually snake venom, and incubate it for 2 to 3 minutes. And then add the calcium, the clotting starts. If the protein C is present in the patient plasma, then it leads to inhibition of factor 5 and factor 8, which lead to prolongation of the clot formation. In chromogenic assay, the patient plasma and protein C activator, which is snake venom, is incubated, and then a chromogenic substrate is added, which have a chromophore and a synthetic peptide, where activated protein C is cleavage at that side and release that chromogenic substrate. So if the quantity of protein C is present in patient sample, that much protein C will go in its activated form and it cleaves that synthetic peptide at this cleavage site and release the chromophore. So it is directly proportional. The color of generated by this substrate is directly proportional to the presence of protein C in the patient sample. So these are the better, as I told before, that they do not affected by many other variables. So what we have to remember is the pre-analytical issues when we do or interpret these tests. So at least they should not be measured in acute phase, as I told, and during the anticoagulant. If direct oral anticoagulant are patient is on direct anticoagulant, then they can give you the false negative results. However, we can do the chromogenic assay because it will negate these things. If a patient samples, you find that protein C, protein S, and antithrombin all are low, then you should think more of acquired condition like DIC and others, because all three proteins cannot be reduced in any patient. So that's why the other testing, other things we have to use, and we should never ever forget the reference range of these proteins, especially in the infants and neonates in childs. So usually most of the protein C and protein S get normal by the age of 6 months or 1 year. So next is protein C deficiency. We know it is act as cofactor for protein C, and what is mainly work as a natural anticoagulant is the free protein S. So there are two types of protein S. One is free protein S and other is bound to the proteins. So protein C deficiency is also a rare cause for thrombophilia in patients who are presenting with thrombosis. This could be homozygous, heterozygous, or compound heterozygous. So there are a list of various causes which can associate with low values of protein C when there is a lupus anticoagulant or any of the anticoagulant, oral or heparin, they are present in the samples. And there is, along with that, there is also the acquired causes for low protein S, that is pregnancy, acute reaction, or liver disease or DIC. So we should always interpret the value in context to these factors. So as I told, that protein S is a cofactor for protein S. So the assay which to assess the activity or the presence of protein S in the patient sample could be APTT, PT, or factor 10 or Russell Viper venom time test based. So these tests, in these tests, what is this general principle? If I tell you, then as protein S is acting for the cofactor for activated protein C, so it increases the potentiality of protein C. So we incubate the patient sample with activated protein C or its activator, and we then try to find out the clotting time. So what is usually we use the test and recommended tests to measure the free protein S in majority of the labs. So these tests can be done by the nowadays majority of the automated analyzer Radics Immunovist assay is more commonly used, and total protein S can also measure, which measures both free and bound protein. So how we should interpret the result? So if we have all three things, total, free, protein S, and protein C activity. So if all three are decreased, then it is type 1. If total and free proteins are normal, but activity is decreased, then it is type 2. If total protein is normal, but free and activity is decreased, then it is type 3. So how should we interpret the result of protein S? So if we have done free protein S, which is recommended to do the first test when we investigate a patient with protein C, if it is low, and we have already ruled out the all acquired causes, so then either it could be type 1 or type 3. To do the total protein S, if it is low, then it is type 1. If it is normal, then it is type 3, and they should be reevaluated after 4 weeks. If we have excluded the acquired causes and still the protein S is normal and there is a strong clinical suspicion of protein S deficiency, then we should do the activity assay. If it is normal, then we should exclude the protein S deficiency. If it is low, then it is type 2. And again, reconfirm after 4 weeks. So another test which we commonly do in our lab is antithrombin. So antithrombin directly inhibits thrombin, but it also inhibits factor 7, 9, 11, and 12 and other things. So this antithrombin deficiency is called hypercoagulability state, and it is one of the things which is increase the risk 5 to 50 folds as compared to the person who is not having the antithrombin deficiency. So these deficiencies can be also classified as type 1, where is quantitative, means the quantity and activity both decrease in the proportion, and type 2, that is qualitative, where the antigen is normal, but activity is reduced. So these can be assessed by the functional assay. Usually what is recommended is chromogenic assay. Sorry, this. Recommended is chromogenic assay as compared to the activity assay because they less interfere with it. So usually these assay is either thrombin based or factor 10 based. So what we do here, we take the patient plasma with excess of thrombin in heparin, and then we rely on that the antithrombin which is present in patient plasma will inhibit the thrombin. And we make a reference curve with known value of known sample, known plasma, reference plasma. And then we try to find out how much the activity is present in patient sample. There is also other method to assess this antithrombin, like ELISA or latex agglutination, which is rarely done nowadays. Majority of the people are doing chromogenic assay for antithrombin deficiency. So there is lot of acquired causes which can give you a low antithrombin deficiency. Especially we should who is working in hematologist setting and they're treating the patient of ALL, they should always remember that patient who have on LS pregenase, they have give the false value of low antithrombin. So both anti-10 ASA and anti-10 and anti-2 2, that antithrombic related anticoagulant drug, they interfere with these tests, so we cannot assess antithrombin if the patient is on either of this. So, how to interpret the result of antithrombin test? So, if antithrombin activity we have done, if it is normal, we have to find out whether patient is on direct anticoagulant or not. If yes, then we should repeat the test. If no, and there is no other evidence for antithrombin deficiency or other acquired cause, then we can say the patient has normal anticoagulant level, antithrombin level. If it is low, but there is history of recent heparin therapy, then we should repeat the test again once the heparin is stopped. If there is no heparin therapy and there is no evidence of any acquired things, then we should measure the antigen. If antigen is low, then this is type 1. If it is normal, then we can classify it type 2 antithrombin deficiency. Whatever test results we get, if it is low, all should be confirmed after a repeat testing, at least 4 weeks apart. So, as I showed, we have seen in the first slide that antifibrinolytic pathway is also very important. So, it will decide how the clot will lyse or it stay. But the problem is that to monitor or to find these deficiencies, the assays which we do in our lab, majority of the lab don't do these tests because the reality of these disorder and the knowledge and expertise which we required is not, and the equipment's not usually available in the lab, and the reproducibility is poor. So the condition like dysfibrinogenemia, plasminogen deficiency, tissue plasmin or erythrophilic plasminogen activity deficiency, or overexpression of plasminogen activator inhibitor 1, or overexpression of TAFI, they all can lead to less neurolysis or decrease conversion of plasminogen to plasmin that will lead to hypercoagulable state. So we should always keep in our mind this could be either of the cause for thrombophilia. So these are the routine tests or tests which we usually do in our lab. But there is also role of can these global assay like viscoelastic spirometry, like thromboelastography or TOTEM or thrombin generation time or platelet analysis, they can help us to find the hypercoagulable state. Yes, so there are many research papers which shows that both in TAG and GROTEM, if the clotting time for our time is shortened or the MA or this maximum clotting things is increased, it is suggestive of hypercoagulable state. Similarly, for the thrombin generation time, if the lag time is reduced and the peak height is increased or total thrombin generation potential is increased, they are suggestive of hypercoagulable state. Similarly, in clot wave analysis, if derivative 1 and 2, the height of peaks are increased or the area is increased, that is again suggestive of hypercoagulable state. So there is a lot of condition where acquired thrombophilia can be occurred, but I will just discuss the 3 of one, which is the specific testing is available and we should know how to do this testing and when we have to do. That is, one is Apla's syndrome, other is PNH and HIT. So as we know, for the Apla's syndrome or antiphospholipid syndrome, there is criteria either thrombosis, either vascular or pregnancy morbidity, either of one, along with any one of the criteria, that is mucus anticoagulant, cardiolipin, or anti-beta-2 glycoprotein 1 antibody in 99th percentile for them. So that should be present to make a diagnosis for antiphospholipid syndrome. So when we should do the testing, as it is more similar to what we have read in journal. So any young patient, unprovoked activity, unusual site, ischemic transits ischemic attack or ischemic stroke, arterial thrombosis, microvascular thrombosis, decreased pregnancy loss. So these are the few conditions where we should think of this. So what are the tests available in lupus anticoagulant? As I told, this cannot be done in acute phase and the patient is on oral anticoagulant. But uh, anti-cardiolipin antibody or anti-beta 2 GP1 antibody, they can be done by the ELISA method or CLIA-based method, which is now present in many of the automated analyzers. So that can be done. For PNH, the patient usually present with anemia, uh, hemoglobinuria, and all those things. So when we suspect a patient who presented with thrombosis, young patient has thrombosis at unusual site like intraabdominal, cerebral, or splenic vein thrombosis, and present with Budd-Chiari syndrome, and there is evidence of hemolysis or cytopenias. So majority of the lab do this testing for detection of clone on WBC, the neutrophil and monocyte, as well as on RBCs by flow cytometry test. So other condition which is very important in ICU settings where a lot of heparin or in surgeries, especially in the cardiac, where a lot of heparin is used. So there is chances of developing heparin-induced thrombocytopenia and thrombosis. So the clinical score for probability of hit is usually called as T4 score system, which is a very good probability when the score is high, is 6 to 8. And there is two type of assay to confirm it, either immunological assays or functional assay. The gold standard assay is protein release assay, but it is very difficult to find the radioactive uh, things in your lab, and only for the research purpose it is done. So that is the major limitation of heparin induced platelet activation you can do, but it is again the variability and reproducibility is the problem. So what majority of the people do, either ELISA or the lateral flow, which is point of care test, where it gives you a broad idea about these antibodies. But nowadays, the analyzer, they are now get either latex-based or cumulonimbus-based assay to detect the antibody against BF4. So this is the last slide. Once a case of thrombosis come to us, how we should approach it? Is it first episode of thrombosis, and we have ruled out all the acquired causes like which can be provoked and strongest factor for causing this hypercoagulable state. So we should no need to do the workup of thrombophilia. But if there is no acquired causes and patient is young, unprovoked thrombosis and unusual site of thrombosis, or there is recurrent pregnancy loss or sub-pregnancy morbidity, or even we should consider the testing in those patients who are young, strong family history. There is debate on it, but still we can take these cases, or it has been provoked in young patient with weak triggers. So we should consider for workup of hereditary thrombophilia like protein C, protein S, factor 5, leading mutation, or recombinant gene mutations. And according to the situation, we can also work up for the acquired causes like APLA, PNH in particular settings. If these all things are needed, then we have to think about the fibrotic pathways like dyslipidemia and other disorders. In some specific situations, like Budd-Chiari syndrome or Creutzfeldt syndrome, we should work for PNH and JAK2 mutation. If there is neonatal purpura permanens, then we should look for protein C, protein S deficiency. ICU setting, as I told, we should look for it. And in young patient who is having classical features of SLEs or renal impairment, then we should work for a syndrome. If we have arterial thrombosis, then we should look for other things and working. So this is all from my side, and this is my beautiful team, Dr. Ruchi, Dr. Kashyap, who is the head of department, Dr. Manish, Dr. Rahman, and my resident. And these are the main person behind all these work, Mr. Viswas, Mrs. Meena, and Aslam, who works in our coagulation lab. So thank you very much for patience hearing. And now we can think we can have some question answers if there is any.
Thank you, sir. If anybody wants to ask the question, kindly raise your hands in the chat box.
Uh, Sir, if you want to send any sample with non-PCR test for a thermophilia workup to any outsourced lab, so what conditions should the sample be transported?
Okay, so means you want to do the functional assays for thrombophilic or applied protein
Yes, sir,
synthesis
yes.
and recombinant. Okay, so for all coagulation testing, first you have to rule out the pre-analytical variables that patient is not on anticoagulant, and if we can wait the resolve the acute phase. Okay, because they can lead to either false negative, false positive. If these conditions are not there and you want to send the sample, so you can collect in citrate vial and make platelet or plasma and then allocate it and freeze it. And then it should be sent to the reference lab in dry ice.
Thank you, sir.
Thank you everyone for listening this talk and be with me for on this important day. Thank you very much.
Thank you so much, sir.
Good night.
Good night, sir.